Now, there's been a lot of publicity about post-colonoscopy colorectal cancer, but little attention for post-endoscopy upper GI cancer. But there is a problem. There's not just a problem, there's a problem that is not getting better. Next slide, please. So we have here on the left the data of the PCRC 3-year, that's the cancers appearing between 6 and 36 months after a negative colonoscopy. And you can see in the top bit of the left panel, there's a declining incidence over time. This is certainly in England. But if you look at the right panel, you'll see that the rate of cancer appearing after an endoscopy that doesn't show cancer is, if anything, increasing slightly. This is in England. And the absolute mean rate is about 8.5%, which means that endoscopy is only 91.5% sensitive for either diagnosing or, let's really be clear about this, preventing cancer. And of course, cancer of the upper GI tract is vastly more impactful than that of colorectal cancer. So there's a real issue here. Now, Nigel has done a root cause analysis of a number of upper GI cancers, and there's a lot of detail on the slide, but I just want to draw your attention to the 2 red boxes. So this framework is sort of based largely on the World Endoscopy Organization framework for post-colonoscopy colorectal cancer, but it has been modified to suit the upper GI domain. But the key take-home message here is that 60% in this relatively small audit is really related to lesion recognition and what happens afterwards, particularly if the initial assessment is inadequate. So there's a big issue here, not just in lesion recognition, but actually in the management process that follows it.
I want to do a few things. The first thing I want to say is a little warning, and Roland has alerted you to potentially some data, but this is just like one case. And so this is a case we just picked out of what we've seen in the last 12 months in Ghent. And this was a 37-year-old woman who presented with coffee ground vomiting. Wasn't very much of a hemoglobin drop. Everybody thought that probably there was not much wrong. We did a gastroscopy. This was one of the images taken in the gastroscopy. Patient was discharged with a gastritis diagnosis, found to be Helicobacter positive and treated. And then she came back with hematemesis 3 months later. And this is what we saw. And unfortunately, she had this in roughly the same position as what's probably here. I mean, you can debate it. Sure, you can debate it, but what you can't really debate is that something was missed here on the graded curvature in the first gastroscopy. And of course, the patient is, with his diagnosis, having a serious issue. And if you take a nice video and you take it to the multidisciplinary meeting, or you take it to your local interventional endoscopist, you can have a reasonably solid discussion about whether or not an attempt at endoscopic resection should be made for the lesion that's being discussed, or whether the patient should just be removed to sent for surgery, and or some other type of therapy like radiotherapy. And this we'll come back to multiple times, so don't worry that you've not taken it in. So Matt has made the comment already, but if a lesion is nodular or bulky in Barrett's esophagus, it is not as concerning as it is if it's a squamous lesion. So this, for example, if it was a squamous lesion, would be deeply invasive, almost certainly, but in Barrett's, potentially is endoscopically resectable. And these are some examples from the paper that published with Michael in 2020 on early gastric cancer. And again, you can see better imaging. I think that they're flat. They can be ulcerated in the center. This is an adenocarcinoma in the stomach. So they can also be very subtle and very small. Big patches, they can often be very defined, et cetera, et cetera. And they can be very, very subtly on the incisura. So go looking for them. Okay. This is not a useful video. Good that it doesn't play. And the key concept is the demarcation line. So mentioned multiple times by people in this talk. We will show you some examples of it. And if you use that and you use a demarcation line, you can have much better outcomes of finding gastric cancer, early gastric cancer, and differentiating it from inflammation, which is often quite difficult, actually. And again, this concept of regular, in this case, they call it irregular and absent. I might say regularly irregular and totally irregular, but whatever, it's the same thing.